Okay, looks like we've got just about everybody. I'm sure there'll be a few more people joining, but thank you for being with us this afternoon. We'll start with some introductions. I'm Paul Saucier, Director of the Office of Aging and Disability Services. Betsy?
Hey everyone, Betsy Hopkins, Associate Director overseeing Developmental Disability and Brain Injury Services.
And Nikki?
Hi, I'm Nikki Hoy. I'm the training specialist here with OADS.
And Craig?
Hi, I'm Craig Donnan. I'm Project Manager for the Lifespan Project.
And we'll be turning this over to our actuaries in just a minute, so I'll wait and let them introduce themselves in just a moment. I wanted to just welcome you all. Thank you for participating today. We have a good crowd. This is the launch of a formal rate study for Lifespan, the new Lifespan program that we're looking to launch in 2025, as well as sections 21 and sections 20 and section 29. As you all know, we are looking to launch a new Lifespan waiver in 2025. In order to do that and stay on that time frame, we need to submit a waiver application to CMS that includes rates in early 2024. Lifespan will most definitely have some new services that we don't offer today, but it will also have many services that are either similar to or the same as services that we offer in section 21 and 29. We haven't had a comprehensive study of the 21 and 29 services in several years. And so today we're formally launching the rate study for 21 and 29 with intent to update those rates in 2025 along with the launch of Lifespan. So with that backdrop, I'm going to turn this over to our team from Burns & Associates, who are our contractors to do the actuarial work on this study. Stephen?
Great. Thank you, Paul, and good afternoon, everyone. I'm Stephen Pulowski. I'm with the Burns & Associates Division of Health Management Associates. We have a PowerPoint presentation that we will walk through to provide some of the details and major tasks and timelines for this particular engagement. Before I get to that, I've been asked to share just a couple of housekeeping notes. The first is, as I'm sure everyone has noted, this webinar is being recorded, and ultimately the recording will be posted on the OMS website. I believe that link will be shared via chat during this presentation. As I said a moment ago, I have a presentation to walk through to make sure that we're conveying what it is we need to convey, but we're also hoping to save some time at the end of today's webinar to answer questions that folks might have at this stage of the process. Chat has been disabled for this webinar. However, you can use the Q&A or question and answer feature to submit those questions. As I said, we'll be holding those, however, until we get through the presentation, just to ensure that we are able to get through all the material that we need to get through. Additionally, folks have been muted. However, if we need any clarification on questions that come across that Q&A function, we will be unmuting folks to ask for that clarification. I think with that, I can go ahead and ask that our PowerPoint be shared with the group, and I'll run through what we need to go through. So on the agenda on the next slide, we'll provide a bit of an overview about who it is we are. We'll spend a fair amount of time talking about the approach that we take when we're setting rates for these types of services. And when I say these types of services, I'm referring to home and community-based services, such as those covered through the existing Section 21 and 29 programs, as well as the proposed Lifespan waiver. Then we'll take some time to talk through the specific tasks that we'll be following in order to complete this rate study with OADS and OMS. And then ultimately, as I said, we'll wrap up with a brief discussion and next steps, leaving time, I hope, for some questions from all of you who are listening in on this webinar today. So wanted to make sure that we're laying out the scope for this particular engagement. Fundamentally, one of the primary tasks is to establish rates for the new lifespan waiver program. As Paul said, that program is in the formative and planning stages, but is looking to be launched in 2025, which in government time is right around the proverbial corner. One of the things, of course, that will need to be determined is the level of payment for services delivered through that particular program. To state what is obvious, we don't have a track record yet. So one of the things that we'll be doing is relying upon existing Section 21 and 29 programs as a foundation for establishing rates through the lifespan waiver. Now, I'll quickly note that that doesn't necessarily mean that rates will be identical across programs. In some cases, that may well be the case. In other cases, because of different expectations or standards, similar services might have different rates. But we still need to start from somewhere, and that somewhere is the Sections 21 and 29 programs. In addition to needing that foundation for the lifespan waiver, it just made good sense to ODES to conduct this rate study at this point in time. It's been a number of years since a comprehensive review of the rates for Sections 21 and 29 has been undertaken. Of course, that's not to say that rates have not been adjusted during that interim period. There's been a number of legislatively appropriated rate increases that have occurred. But in terms of the foundation for some of the rates covered by these programs, it's been quite a few years since they've been reviewed in a comprehensive fashion. And I'll also note that whenever we're conducting a rate study, certainly we're looking to establish those bottom lines. How much is the state going to pay for something? But at the same time, we're considering broader aspects of the overall reimbursement model. So that includes things like how services are reimbursed. What's that basis of payments? Is it on a 15-minute basis or a daily basis or some other unit of service? Ought there be consideration to existing limits or potentially new limits on the amount of services that can be delivered? For services for people with intellectual and developmental disabilities in particular, one of the questions we're always looking to explore is to what extent should rates vary based upon the acuity or the support needs of the individual? Because we know that folks with IDD are on a continuum. There are people who are quite capable, and there's other people who have some pretty significant disabilities in terms of meeting their own support needs, and to what extent should rates accommodate those differences in needs? We'll think about program rules such as staffing requirements, et cetera. So that's by no means an exhaustive list, but what we wanted to convey is that when we're doing a quote unquote rate study, it really is a broader review of the overall framework for reimbursing providers, not just the how much, but the how and the what's and the whys as well. Moving to the next slide, we also wanted to ensure that folks are aware that there will be multiple opportunities for providers and other stakeholders to be involved in this process. We intend for this to be inclusive. Certainly, we're looking for feedback on this presentation, and certainly if there's any questions that arise after the presentation, say that you go back and review the recording, you're welcome to provide your feedback to the folks that you know at the department. At the end of this presentation, you'll have contact information for myself and Tina Harper, who's our lead consultant on this engagement as well. We're also looking to establish a provider advisory group. So this will be a smaller group of providers that's meant to represent the larger community within the state. So it will be diverse in terms of the services delivered, the size of the organization, where in the state they're located, what regions they serve, and the like. And the purpose of that group is not to provide any secret communications, but it is to allow us to have more of a dialogue than is possible when we have 150 or 200 people on a phone call. So we'll be using them as a sounding board at key stages throughout this project. So for example, one of the first meetings that we'll have with that group is going to be discussion of a draft of the provider survey that we'll be conducting, so that we get feedback about whether or not they believe it is inclusive of all the information that we need to gather to truly understand what it takes to deliver services to people with intellectual and developmental disabilities within the state of Maine. But of course, once that survey is completed, it's not going to be limited to this provider advisory group. It's going to be sent out to all service providers, all of whom will be encouraged and invited to participate in that survey. We'll talk about this a little bit more as we get into the presentation, but that is going to be one of the considerations that we look at when we're developing potential changes to existing rates for 21 and 29, as well as the establishment of rates within the lifespan program itself. Importantly, there's going to be an opportunity to comment on the draft rates before we, Burns and Associates, offer final recommendations to the department. So this is a public comment process that precedes what also occurs on the main care side through rulemaking, as well as on the federal side whenever you're submitting a waiver amendment or waiver application. Both of those processes also include opportunities for public comment. But even before we get to those stages, we want to make sure that we've heard from the community, we've vetted that feedback before we're offering our final recommendations to the department, at which point they will then make determinations about how to go through rulemaking and, of course, to get the comments that are required by the federal government. And so from here, I want to just pivot briefly to talking a little bit about my organization as we move to the next couple of slides. So as you've heard me say, we're with Burns and Associates. We're now a division of Health Management Associates, but Burns itself is a group of health policy consultants who, since our founding back in 2006, have really focused on supporting state government, more specifically the state Medicaid agency and their sister agencies, the behavioral health and developmental disability authorities. Since we were established in 2006, we've consulted to about 30 states across the country. Again, those are to state governments. The reason for the mouthful in my introduction now is that we sold the firm back in 2020. So now we're a division of Health Management Associates. But for those of you who've worked with us in the past, which is going to be many of you on this phone call, it's still the same Burns team working with the same Burns clients, doing the same Burns type of work. So really the only difference as it relates to the work that we're doing is going to be the email address that you're going to be communicating through. One of the emphasis that Burns has had since our founding has been working in the IDD field in particular. And within that space, we cover an awful lot of ground that starts with things like policy developments, including helping states think through service standards and expectations and limits and billing rules and the like, all the way to the other end of the spectrum, which is program evaluation. How well is a program performing? In between, of course, there's an awful lot of space as well. One of the things that we're known for, and as much as a consultancy can be known, are provider rate studies. And I have a map that I'll show you in just a second that illustrates where those have taken place over the years. We also get involved in a number of projects where the IDD authority is looking to use an assessment instrument, such as the supports intensity scale, to assess individual need and at times tie provider reimbursements or individual budgets to the results of those assessments. I think the next slide provides just a graphical illustration of where it is we've done types of work with IDD authorities in particular. So again, this is not the list of all the states in which Burns has consulted, but looking particularly at those IDD programs. Those that are shaded in that rather pleasing turquoise color are states in which we've conducted comprehensive rate studies. So we've done now over the years 12 or 13 or 14 rate studies, I should say, in 12 or 13 or 14 states that are very similar to what we'll be looking at here in Maine, where we're reviewing everything kind of from beginning to end, looking at service definitions, making sure we understand that, doing primary and secondary data collection, and ultimately developing new reimbursement frameworks. As I also said, we don't only do rate setting. So what you'll see shaded in the more charcoal-y color are those states in which we've had IDD-related engagements, but they've not necessarily been reimbursement focused. So for example, in one state, we helped develop pilot programs for young adults with autism who are aging out of the K through 12 system. In a couple of these states, we helped them establish budgeting guidelines based upon assessment instruments like I talked about on the previous slide. So again, kind of a wide array of other activities have occurred within those grade states within this map. As shown on the next slide, and as I think a lot of you are already aware, Burns and Associates has been contracting off and on with the state of Maine for quite a few years now, almost entirely on the provider reimbursement side. So this shows you the previous IDD related projects that we've undertaken, as well as the results of those. Most of our projects, though not all of them, have resulted in the implementation of our recommendations. Of course, one obvious exception to that is the first time that we worked with ODES and with the department more broadly on sections 21 and 29. That was coming out of the recession back in 2010-11, and we looked at reimbursement rates a couple of years hence, and ultimately those recommendations at that time were not implemented. However, a few years later, we looked at a smaller suite of services covered through sections 18 and 20, as well as 21 and 29, and ultimately those rates were adopted. So some of the rates in effect are based upon the rate study that we conducted here 3 or 4 years ago. I don't want to read the remainder of the list, but we just wanted to make sure that folks are aware of what it is we've done in Maine over the years and the kind of status of those particular projects. Briefly, although I don't have a slide about it, just reiterating, there's going to be a couple of people from Burns that you're going to be hearing from throughout the duration of this project. Today, you're primarily going to hear from me. I've been with Burns, I think, since 2009, so quite a few years now. I've led all of the Maine-related projects that you saw on the previous slide, as well as headed up Burns's home and community-based services consulting team since, I don't know, 2011 or 2012. Although you won't be hearing from her much today, I'm joined on this project by Tina Harper. She was with us a number of years ago and supported some of our Maine work and rejoined Burns within the last few months, and she'll be the lead consultant. So on a lot of the day-to-day activities, for example, the coordination of the provider survey, she'll be the primary point of contact. So with that, I'll pivot to our approach to setting rates for home and community-based services. As you heard and as you saw a couple of slides back, we've done these types of projects in a number of states. And as a result, as you see on the next slide, we have developed a fairly standardized approach at a high level. Of course, the details are always dependent upon what a state's looking to accomplish. Sometimes it is, strictly speaking, a rate study. We want to update how much we're paying for given services. More oftentimes, it's part of a larger program initiative, the establishment of a new program like we're talking about here in Maine, particularly the adoption of an assessment instrument like we're talking about here in Maine as well. So although we have a standard process that we follow, the actual details and certainly the results are going to be customized to the unique needs of each state in which we're working. But talking about some of the hallmarks of our approach, we refer to the way in which we set rates as an independent rate setting approach. And all that we're really trying to convey with that statement is that we're not dependent on any single source of information. And if you look at the colorful box at the bottom of this slide, this talks about some of the variety of sources from which we gather data that will ultimately inform the development of reimbursement models. As you'll hear about in more detail in a few minutes, we always start with a review of a state's standards and requirements. And that's the very fundamental start of all of these projects, is understanding what it is that state wants to buy, how it is they're defining services. As I opened with in the first couple of slides, we also rely on feedback from providers and other stakeholders through a variety of channels, such as the provider survey and the public comment process. We also look for information from published sources. And again, for those of you who've worked on a rate study with us in the past, you're going to be well familiar with what many of those are, but that includes things like Maine-specific wage data published by the Bureau of Labor Statistics. We use the IRS's reimbursement rate when it comes to estimating the vehicle-related costs of travel, et cetera. And then, dependent upon the given project, we'll sometimes do a number of special studies, which could include things like rate benchmarking, analysis of inflationary trends, a more in-depth review of trends within the labor market and the like. So again, that's going to be dependent upon what it is we're trying to accomplish with a given project. But when we tie it all together and try to convey what it is we're looking to accomplish, the fundamental thing that we're looking to do is build rates that reflect the cost that providers incur to deliver services consistent with the state's requirements and individual service or treatment plans, right? That's what it is we're looking to do. We believe it's the state's job to define the services. They're the ones who are ultimately accountable to the federal Medicaid program. But once they define those services, we also think that states have an obligation to pay rates that allow providers to deliver on those services. And that really is what it is we're looking to accomplish, is to make sure that the reimbursement is adequate to allow providers to deliver services consistent with what the state's expecting them to do. And the last point I'll make before we move off of this slide is we're sometimes asked, going back to the bottom part of this slide, why we're not just relying exclusively on provider cost data. And for the providers listening in on this call, I think the answer to that is going to be obvious. Providers' costs, particularly within the IDD space, are going to be a function more than anything else of the rates that they're currently being paid. Because when you come down to it, the state Medicaid system is really the only game in town as it relates to provider payments. Now, that's an exaggeration. We know that there are some individuals who might be able to privately pay for services. We know that in a very limited number of circumstances, there might be other public funding sources. But by and large, it's the state IDD authority through a Medicaid program that's paying almost all of the reimbursement that IDD providers are receiving, which is different than, say, for example, hospitals who have a diverse payer mix. They accept Medicare. They do have commercial insurers. They do have a greater proportion of people who are able to privately pay. And as a result, even if Medicaid rates perhaps aren't what they ought to be, they're able sometimes to shift expenses to other payers. And of course, that's not controversial. There's a lot of research out there that shows that there is a cost shift between Medicaid and other funding sources. But when it comes back to IDD services, if you're only relying on a single payer, like the state's IDD system, your costs are going to be a function of what you're being paid, right? Because you have to live within your means. And what that results in, we often find in our work across the country, is that providers' expenses are sometimes constrained or less than they ought to be in order to kind of optimally deliver services. So for example, sometimes providers can't pay direct support professionals what they think they ought to be able to pay them because the rates they receive from the state aren't adequate to do so. So again, the unique reality is different for each state based upon their current payment models. But that's why we're always going to be looking at information beyond just what we gather from providers and supplementing that with information from other sources. Moving on to the next slide. Ultimately, and I have an example of this coming up in a slide or two, we will be putting together rate models that illustrate how we get to the bottom line rate. So when we do this work, we never simply report out, we think a rate ought to be $40 an hour or $200 a day. We're going to use a school term, we're going to show our work. We're going to tell you how it is we got to that bottom line. And for example, if we're talking about that $40 an hour rate, it's going to be based upon this assumption for how much the direct support professional earns, what their benefit package looks like, how many billable hours they're able to provide, the level of administration that we're providing at the agency level, et cetera. And what that allows us to do is to have an informed conversation about the rates themselves, because we've been at this long enough where if we simply said, we think a rate ought to be $40 an hour, the community is going to say, we think it ought to be 44, and we're going to say, nuh-uh, and they're going to say, uh-huh, and we're really not going to get anywhere. By detailing exactly how we got to that bottom line, we're able to get that more targeted feedback, and a provider or stakeholder might say, rather than the wage assumption of the DSP wage assumption of X, we really think it ought to be Y. And hopefully they'll provide some additional supporting documentation about why Y makes more sense than X. And it allows us, again, to really challenge ourselves to make sure that the individual assumptions that we've made are sufficient and tie back to that goal I covered on the previous slide, that we're building rates that actually reflect the cost of delivering services. I always want to spend just a moment talking about the differences between assumptions and reality, particularly for providers who are listening on this call. The rate models themselves and the assumptions in particular are never meant to be prescriptive. We know that every provider is unique in terms of the needs of the people they serve, what their workforce looks like, et cetera. And so our rate models are meant to reflect the typical cost of service delivery, but we certainly accept that for any given provider, some costs are going to be lower than assumed, and other costs are going to be higher than assumed. that's okay. Providers don't have to target the individual assumptions we have in our rate model. Just because we assume that DSP wage is X doesn't mean that all of their staff have to be paid X. It could be for some providers that their staff determine that it's more important to have more generous benefits that we've assumed, that they prefer to take a lower wage and have better health insurance or maybe a retirement contribution. Or the reverse could be true, that some staff value wages more than other benefits. And so the idea is these models are meant to allow us to have that informed conversation reflect typical costs, but they're not meant to be descriptive of what any given provider experiences. And so, for example, it should not be viewed as a limitation or a requirement, right? If we've assumed this level of, say, mileage within a rate model, that shouldn't say that providers assume that that's always going to be the reality for their particular organization. The other thing that we point out, and this is evident in some of the projects that we've done in Maine over the years, is that a single service may have multiple rates to account for various differences. And those differences are summarized here once again in our colorful graphic. So oftentimes, particularly in IDD programs, rates will vary based upon the level of need of the individual. Talking about a continuum, so particularly when we're talking about shared supports, there are many states that will pay higher rates for people with higher acuity because they're getting more intensive staffing, and then lower rates for folks with lesser acuity because they're served in groups with more individuals. So on a per person basis, the cost is less because it's being spread over more individuals. In some states, including kind of in a limited way, some of the work that we did in section 18 and 20, which I think was also carried over to 21 and 29, will vary rates based upon where the service is delivered. So that's somewhat common for day programs where there'll be higher rates for community-facing supports than center-based supports because typically you have more intensive staffing needs in the community. There's also more oftentimes time necessary to develop programming within the community versus programming in a center-based environment. We also oftentimes see that for more professional type services, clinical services like a therapy or nursing services, where if people are coming to you, you're able to see more people during a shift. Whereas if you're driving to them, because you're going from one house to the next, you're going to see fewer people and therefore have lesser opportunities for reimbursement. So sometimes you'll also see different rates on that basis as well. In some states, although not historically in Maine, if you look at our previous rate studies, rates will vary based upon geography. And that looks at things like cost of living differences as well as travel differences. And then another basis sometimes are staff qualifications and training. A really obvious example of that is nursing services. If we're asked to set rates for nurses, we're never going to set the same rate for an RN and an LPN because, of course, the market suggests, and really more than suggests, details that they are paid at different amounts, right? RNs earn substantially more than LPNs. And so it would not be fair to a provider to pay the same rate regardless of who's delivering the service. So this is not meant to be, again, an exhaustive list, nor necessarily the list of services differences that will occur in this rate study, but it's meant to illustrate the types of things that we're going to be looking at to make sure that when we build a reimbursement framework, we are accounting for providers' expenses and how they might vary based upon these types of factors. And so moving to the next slide. When we set rates for home and community-based services, there's really going to be 5 core factors that you're going to see in every one of the rates. 3 of them relate to the direct care worker. That's their wage, their benefit package, and what we refer to as productivity, which is the measurement of the number of billable hours they're able to provide, and more particularly, the cost of that non-billable time. And then the other 2 relate more to agency level expenses, and we divide that between program support and administration, and I'll provide definitions of both of those here in a moment. In addition to those 5 key factors that you're going to see really in nearly every one of our rate models, there will be other factors that are more service specific. So if it's a shared service, we'll have assumptions about staffing ratios. If it's again, a shared service or sometimes more of a site-based service, we'll make assumptions related to things like attendance and occupancy. If it's community-facing, the worker has to either drive to get to the individual or transport the individual, we'll make assumptions related to transportation. If a program requires supplies or is delivered in a clinic or center-based environment, we'll make assumptions related to those costs as well. Again, by no means an exhaustive list, but we just wanted to illustrate that outside of these 5 core factors, there'll be consideration of other costs that are more service-driven that we'll also be incorporating within our rates. And I think on the next couple of slides, we'll show an example. And so this is the home support quarter hour rates that arose from the rate study a few years ago for sections 18, 20, and 21 and 29. I'm not going to go through the numbers on this slide because this is one of the rate models, of course, that we'll have to reevaluate given the time that has passed. But what we always want to reiterate is we're not just going to show that bottom line, which in this case is $9.49 per 15 minutes. And I'll also note that that's out of date because that's been increased at least a couple of times since this rate model was published. Rather than just showing you that bottom line, we're going to show you exactly how we got there so that when it comes time for stakeholders to weigh in, they'll know how it is we developed the overall rates and can provide more targeted feedback to us. And it just allows that greater degree of transparency to all interested parties, whether those are providers, policymakers, or other stakeholders. Briefly running through those 5 key factors I mentioned a moment ago, I said 3 of them relate to the direct care worker, wages and benefits, which is the largest component of the overall rates whenever we're talking about home and community-based services, which is different than, say, setting rates for a hospital, because hospitals' costs really aren't driven by the wages paid to doctors and nurses. It's the cost of the facility, the capital expense, the expensive machinery like MRI machines, of course, the supplies and prescription drugs and everything else that flow through a hospital. But when it comes to home and community-based services, what we're talking about more than anything else is an hour of somebody's time. And so as a result, that's the single largest expense. And we spend, as a result, a lot of time trying to think through what's an appropriate wage level. And we look at the provider survey, we look at the BLS data that I referenced, and sometimes we'll supplement that with other labor-related research. Another important aspect of the rate models for the direct care worker components is what we refer to as productivity. And as I defined a moment ago, that's that measurement of the number of billable hours that a staff person can deliver in relation to the total hours that they work. And what I mean by that is if an individual is, say, participating in a staff meeting, that's not going to be a billable activity, right? You can't bill main care for that time. However, it's part of what it takes to run an organization, right? You need to share information with your staff. You need to let them know about updates and policies, procedures. Maybe you're providing a presentation on best practices or emerging research within the field or what have you. And so that's part of their job. They're on the clock when they're in those staff meetings and really is what it takes to deliver high quality services. But because you can't bill for that directly, we need a mechanism to allow for those costs to be layered into the time that you can bill for. So we provide the analysis of what that ratio should look like or could look like, and we use that to effectively inflate that wage and benefit expense to cover the non-billable time and spread that over the billable hours. And then on the next slide, we repeat that rate model, but just spend a moment talking about the remaining components of the rates. And so if you can flip to the next slide, back one. I said that we divide the agency expenses between 2 categories, program support and administration. And we think it's important to differentiate between the two because they really are 2 discrete functions. Program support, let me start with administration. So administration, I think everyone intuitively understands. It's those functions that exist regardless of the line of business that you're in or the service that you're delivering. It doesn't matter what it is an organization does. It needs some level of executive leadership, some type of a business office, some type of a human resource function, probably some type of an information technology function alike. And so, although in a different context, I think it kind of falls under that Supreme Court comments about you know it when you see it. But for program support, this is, again, not directly billable, but it really is tailored to the unique needs of a given line of business or a given service. So that includes things like first line supervision. It includes things like program or curriculum development, quality assurance, et cetera. And we think it's important to differentiate between those two, because if we lumped everything together and called it, say, overhead, that's going to do a disservice to providers when it comes time for policymakers or CMS to review these rates. It really would overstate what is truly administrative in nature, because those program support functions really are integral to the delivery of high quality services. And so when you look at almost all of our rates, not all of them, but almost all of them will have different assumptions related to program supports and to administration. And then, as I said, other costs vary by service. For home support quarter hour, it's pretty straightforward, since this is, generally speaking, a one-to-one service delivered in the community. So the only other cost factor outside of those key five that you see is the assumption related to mileage. And then one of the particularities of Maine is there's the service provider tax that's added to some services as well. So those are the other factors that get built into the rate for this home support quarter hour. If you look at rates for community supports, it's going to include more. It's going to include the facility expense. It's going to include staffing ratio. It's going to include the assumed attendance rates, but then it wouldn't fit on this slide. So we wanted to go with a simpler rate model without cramming the text to be too small. And so on the next slide, I wanted to wrap up this section of the presentation, reminding my client why it was a good idea that they've hired us to set rates in the way in which we're setting rates. And so we really see three key benefits to this approach to rate setting. The first, and I hope folks will agree with this, is that it's transparent. As you've heard me say a couple of times, we're not going to simply say that a rate ought to be $40 an hour. We're going to show you it's based upon a wage assumption of this and a benefit package that looks like this, and productivity and this rate of overhead, and et cetera, and et cetera. And so although we never expect and we never achieve complete consensus on our rate models, at least folks understand what it is we've built into the rates, where that information was gathered, what calculations were performed, et cetera. And that allows us, again, to have that informed dialogue. Additionally, it allows the state to advance policy goals and objectives, which is one of the key, I think, considerations of this project on the lifespan side in particular. So are there specific things that we're looking to encourage the system to do? And you'll see some of the examples listed here are things like investing in the direct care workforce, which has been a focus of systems across the country here, really heating up quite a bit during the pandemic, and certainly lasting even in this post-pandemic age that we're living within. It could mean reductions to staff to client ratios. It could be, how do we incentivize more community-based services? So there's lots of things that state might want to achieve. And although we always say that good rates never trump bad policy, we do want to build rates that are reflective of the policy intentions of the state. And then importantly for our clients, these rate models themselves lend themselves to being maintained over time. As folks are going to understand, and those of you who've been through these rate studies before will, I'm sure, attest, it's a lot of work. It's a lot of work for the state team. It's a lot of work for the providers and stakeholders. It's a lot of work for the consultants. So it really doesn't make sense for this comprehensive rate study be conducted on an annual basis. But we also want to recognize the reality that costs increase over time. And because we've outlined our assumptions within the rate models itself, as those costs increase, a state can, although they're not obligated to, but they can make targeted adjustments to reflect those higher costs. A really obvious example is the IRS mileage rate. As you heard me say earlier, we use the standard business rates in our rate models to reflect vehicle-related expenses, and that gets published usually once per year in December. And so as that value increase, or most years increases, the state can go in and substitute the old IRS rates with the new IRS rates, and the rate model itself automatically recalculates. I want to emphasize that there's nothing automatic about that really in any states, that it's still, because it's going to have a financial impact, updates to rates still have to go through the state's budgeting and legislative and executive review processes. So I don't want to promise that rates get automatically updated just because a state is working with us. But what we do want to make sure we're clear on is that the models themselves allow themselves to be updated over time. And if they're not updated, it also allows providers and other stakeholders to understand what the basis for those original rates were, and to make their own arguments about whether or not those cost assumptions do or do not continue to reflect their reality. So from here, I'll pivot to the last major component of this presentation, which is going to be the work plan, so to speak, here over the next several months. And so I think we lead off on the next slide with a graphic that shows the three major phases of these types of engagements. The first phase is where we remain right now, and that's conducting background research and having some kickoff meetings. That really is the fact-finding stage. And I'll come back to that point here in just a moment. The next phase of the work is data collection and analysis, which is a combination of both primary data collection, like the provider survey, and secondary data collection, like pulling in the Bureau of Labor Statistics data and applying an inflationary adjustment to move it forward. Again, one example out of many, but that's the sort of secondary data collection that we conduct as well. And then you'll see shaded in, I don't know, mustard or gold or some such phase 3, which is the development of the rate models and the accompanying rules and expectations and the like. And so we'll develop the draft rate models detailing all those individual cost assumptions. And at that point, we'll have the rate study public comment process before, as I said, we move towards finalizing our recommendations to the departments, at which point they go through more public comment processes to amend rules or waivers and the like. So the balance of this presentation is just going to be walking through the tasks associated with each of those three phases in a little bit more detail. So on the next slide, we cover some of the phase 1 and task 1 related work, and that's the background research. And so taking a step back on this, as the map showed earlier in the presentation, we've done an awful lot of rate setting in the IDD space over an awful lot of years. But just because we have that experience doesn't mean we can simply drop the work that we've done in, say, Hawaii or California or Mississippi into a rate model in Maine. And the reason for that is because states have a wide degree of latitude in establishing service requirements for home and community-based services. Although every state covers a somewhat similar array of services, there's gradations and it's not all identical, but every state covers a handful of core services, a group home type of service, day programs, in-home services, and the like. But although every state covers very similar services, the actual expectations for those services can vary pretty significantly from one state to the next. And I just use day programs to illustrate that point, which in the context of 21 and 29, we refer to as community support. So every state covers what the federal government refers to as day habilitation. But things like staffing ratios vary significantly from state to state. In Maine, the historical staffing expectation has been 1 to 3, whereas in a state like Georgia, providers are able to operate as high as 1 to 10. If you're operating at a 1 to 10, your costs are going to look a lot different than if you're operating at 1 to 3, right? It's going to require a lot more staff and therefore a lot higher cost to deliver 1 to 3 versus 1 to 10. So adopting Georgia's rate in Maine just wouldn't make any sense on that basis alone. In terms of things like transportation, in some states that's bundled into the rates. In some states it's separately billable. In other states it's an entirely different entity and payment structure for getting people to and from their programs. In some states, there's the expectation that providers deliver a meal. In other states, they're either silent on it or there's the expectation that folks bring their own meal, et cetera, et cetera. So you can imagine how all of those different policy-related decisions have a significant impact on the cost of service delivery. So although we've built day habilitation rates in more than a dozen states, we have to look specifically at what Maine's expecting in order to build a rate that makes sense for providers within the state of Maine. And again, we just briefly juxtapose that with other Medicaid funded programs like, say, hospitals. There's a standard of care for things like an appendectomy that just don't exist for services in the home and community-based services world. We don't have standards of care. We don't have, for the most part, evidence-based practices. And so we just see a lot more variability in terms of the details of the services that we really need to account for. And we do that always by a thorough review of what's written down on paper, looking at waiver applications, program regulations, whether that's in statute, regulation, or rule, provider manuals, et cetera. We supplement that, however, as you'll see on the next slide, with information from the community itself, starting with the the oversight agency, in this case, ODES, because again, you can only put so much in writing and you want to understand the reality of what's taking place in the field. But then we also have opportunities for us to hear from others, in this case, like a provider advisory group, so that we get that perspective on what's happening at the ground level, what's working well and what's not working well. And so in addition to making sure that we have that thorough understanding of the requirements of each service, we'll be providing an overview of the overall project, like you're getting here today, including the work plan. And then we'll provide opportunities, perhaps in that first meeting, to review a drafted provider survey as an example. As I said, they don't get information that ultimately others don't get, but it allows us to have those more targeted conversations with a manageable group. Ultimately, though, everything that gets shared with that group gets shared with the larger community. And there are, as I said at the very opening of this presentation, a number of opportunities for people to be involved in these rate studies. And so from there, as you'll see on the next slide, we move into the data collection phase. I've made reference now a couple of times to a provider survey, and that is an important piece of our rate setting approach. For those of you who've been involved in one of our rate studies in the past, you'll know that that is not a small undertaking. We do ask for a pretty significant degree of detailed information so that we can develop equally detailed rate models. So for example, we don't just ask for providers' financial statements, because those financial statements are typically rolled up at such a level that it doesn't allow us to really understand the more unit-based expenses. To provide a more concrete example of that, a financial statement will include a payroll expense, but what we're really interested in is how much does, say, a direct support professional earn, because when we build a rate, that's a key assumption that we have to make. So we build these surveys to gather the information at the level of detail that we need in order to build rates that we think are going to be fully transparent. In addition to that, there's information that just doesn't exist at all in financial statements that are more about service delivery. So what are typical staffing ratios, or how many miles is a vehicle typically driven in a week, or how many miles does a staff person drive in a week? Again, you're not going to find that in any financial statement that I've ever seen. And so we need the provider survey to allow us to dive more deeply into the actual delivery of services. I will emphasize a point that I made earlier, which is the results of the provider survey inform, but do not dictate the rate model assumptions. And again, that's just underscoring that earlier point that we understand that providers' rates are going to be constrained by, let's just say providers' costs are going to be constrained by the rates that are being paid today. So we certainly want to understand what those cost structures look like, and it will be something that we do take into account. I don't want to say that it's not, because it is, but it will be supplemented by information from other sources as well. In terms of that survey process, we provide technical assistance throughout. The survey itself will be accompanied by written instructions. We also now embed more instructions directly into that Excel-based survey, so you can click on the cell and the guidance pops up. We will record a webinar where I'll probably be talking about as quickly as I'm talking on this presentation to run through that survey form by form. And then there'll be a dedicated contact person, which in this case is going to be my colleague Tina, to whom you can submit your questions in writing or pick up the phone and give her a call. Ultimately, as that information is gathered, we conduct desk reviews of what's been submitted to us, and then we aggregate the information and we'll be reporting it back out at some point during the rate setting process. We'll reiterate this point when we're talking specifically about the provider survey, but because I have a captive audience here today, I just want to assure folks that we never release provider specific information, and we have a long track record in Maine. So you're not going to find any provider that's going to suggest that we've ever violated that commitment. So everything that gets submitted to us simply gets added to the pot. You know, we lump it all together and then we report out average. So the average DSP salary is reported to be $15 an hour, rather than saying ABC agency pays 16 and XYZ agency pays 14. It's always going to be reported in the aggregate. It's never going to be reported out at any provider specific level. And then there'll be opportunities for us to present that summarized analysis, to present the findings, and at times for us to point out areas that don't make a lot of sense to us, or for the groups that we present to, for them to say, well, yes, that might be what the survey is telling you, but that's because of these realities on the ground right now. So I used the example earlier that maybe the average wage is 15, but providers are experiencing a turnover rate that has grown from 30 to 50% over the last couple of years because they are not able to keep up with wage growth. Or they'll say that transportation related expenses continue to be depressed because of COVID, and maybe there's still some telehealth types supports being delivered. So that presentation of the results allow for contextual conversation to help explain the numbers, because the analysis itself is just us reporting back what was reported to us. They're not our figures. It's simply a matter of us saying, this is what the data shows us. And then for folks to tell us, yes, but, and this is what you need to understand beyond the data itself. Moving on to the next slide. We mentioned a couple of times that we'll be supplementing that provider survey with other research and analysis. And that's likely to include a number of different strategies. We'll collect independent data for individual cost drivers. So we've used the BLS example a number of times, which is, I know, everybody's favorite data source to talk about. We'll also be looking at benchmark payment rates, whether it's within the main care or other state of Maine programs, or in other states, IDD programs themselves, just to ensure that the rates that we're developing make sense. Again, every state's different, and I said that as part of that phase 1 and task 1 review of state requirements. So we never set rates based upon what your neighbors or other states are paying, but we find that to be at least a reasonable reality check, right? If we build a rate that's lower than every other state, or sometimes higher than every other state, it's at least going to prompt us to take a second look to make sure that we haven't missed something. And then, as I also said, we'll be conducting other special studies as applicable. I suppose one of the things that's worth emphasizing to that point is the issue that Paul raised in his opening remarks, and that I tried to reiterate on my first slide, is that we'll be looking at sections 21 and 29 in concert with the lifespan waiver that's been proposed. And in some cases, it may make sense for the rates to be at parity, right? Because the expectations are the same, the staff qualifications are the same, et cetera. It's the same service, just delivered through a different program. But there might also be examples of services that look similar, but do have different expectations. Maybe it's a different type of staff delivering the service with more targeted training that has a cost attached to it. And so that's one of the deep dives that I know that we're going to have to undertake as part of this project, is making sure that when we're looking at rates across these systems, that we're careful about whether or not they ought to look similar, or if they're different, to have a rationale for why it is they're going to be different. And so on the next slide, that takes us to the third and final phase of this process, which is the development of draft rate models. As I mentioned at the top, we'll be considering changes to service standards as well as billing codes and requirements. We call this a rate study, but it is more comprehensive than simply saying, is the rate $40 or $42? It really takes a look at the overall framework for reimbursing providers, as well as the standards that drive providers' expenses. So it's not our charge per se to write service definitions as part of this project. And of course, the service definitions already exist. But if something's missing or ambiguous to us, we're going to ask for additional clarification, and then probably suggest that the state put that clarification in writing as well, so that there's that shared understanding of what the service expects, and that when we build the rate model is in alignment with those expectations. And so, drawing on the data that we gathered from the survey and other independent sources, we'll develop draft rate model structures that identify the cost factors for each service. Sometimes we refer to those as shells, right? It's the rate model without the numbers in it. And that allows us to have, hopefully, a dispassionate conversation, because once you start putting dollars in, passions start to arise. But if we're just saying, these are what we think the cost factors are, we can kind of take that off the table and just look at the black and white. What are the expenses associated with delivering this service? And as we said, a single service may have multiple rates due to things like staff qualifications, service settings, the needs of the individuals, et cetera. Once we built those rate models, then we'll populate them with cost assumptions. So we've identified a DSP wage as one of the key assumptions. The next question is, well, what should that wage assumption look like? And although I didn't cover it when I went through that home support quarter hour slide earlier in this presentation, there's additional material beyond what you see within the rate model. So the packet itself includes appendices. So I know that rate model says the DSP wage is $14.20 per hour. But if you look at Appendix A of the rate model packet, it will show you it's based upon this BLS data with this level of inflation, this mix of occupations, et cetera. So there's more information in the appendices that help explain how those numbers were derived. Again, we're believers in showing our work to the extent practicable, and the appendices that accompany the rate models themselves help us do just that. And then, of course, our states are always kind of particular about, well, how much is this going to cost? And so we also conduct a fiscal impact analysis as part of the development of those draft rates. From there, task 6 on the next slide is the public comment process. I've made reference to this a couple of times, so I'll just spend a minute or two talking about it in more detail now. We'll ultimately develop those draft rate models, and then we will post them online, and we'll have a webinar to walk through those recommendations. Sometimes we conduct that webinar live, sometimes we do a recording, sometimes we do both. But the idea is we want to provide a source where people can go to review our recommendations and to hear us explain why it is we've recommended what it is we've recommended. From there, that opens up a public comment process, and we actually handle that similarly to the way the federal government does through the Federal Register. And what I mean by that is we'll post our materials and our recommendations, and then we'll give providers and stakeholders, generally speaking, about 4 weeks to submit comments to us in writing. We review those comments, and we will provide a written document that summarizes the comments that we received and the state's position on each of those comments. That's a consolidated document, so it'll list every comment received and then provide a response to each, but we don't respond back to individual commenters. And that, again, in the interest of transparency, allows us to explain the changes that were made in response to comments, and when a change was not made, provide the justification for not having done so. Again, I don't think I've been through a rate setting process where we haven't made some changes in response to public comments, but at the same time, I've also never been in a rate study where we've made changes in response to every comment that we've received. And so what I just wanted to make clear is that the public comment process is very much value added. So when I say that there's opportunities for people to be involved at various levels and at various stages of this work, the public comment process is a key point, because we really do, we being the consultants and I know the department, take those comments seriously. It almost always results in some changes to what we originally recommended. And so we've always been appreciative of the thoughtful and thorough feedback that we've received in the rate studies that we conducted in Maine. And then on task 7, we finalized the rate models. Based upon the feedback that we got through the public comment process, we'll revise the models, we'll have that comments document posted that walks through our response to each comment, and we'll post all that online. And then from there, hopefully, we'll provide implementation support as necessary. And that, again, is tailored very much to the needs of the states in terms of the level of change that's occurring and the level of support that a given state needs. But that could include things like estimating the fiscal impact, creating briefing materials for various audiences. If there are more significant changes to the reimbursement framework, we might come up with a phase-in plan, et cetera. So again, this is fairly generic, but it's always our goal to push these projects over the finish line, and we're there to help our clients do that. So I think now we'll move into the last section of the agenda, which is a brief overview of the immediate next steps. So we'll be meeting with the provider advisory group here, hopefully within the next couple of weeks. We're still working on the composition. When I say we, the department's working on the composition, and invitation will be forthcoming. One of the things that we'll be doing in that meeting, just from a timing perspective, is reviewing a draft of the provider survey. Given that calendar, we're looking to have the provider survey distributed by October 13th. That's our goal. Doesn't mean it'll hit it, but that's what we're aiming for, with a target return date of November 13th. And certainly if we can compress any of those time frames, or not any of them, if we can get it out earlier, we'll do so. But there's still some work to be done and some review to be had on that provider survey. We, in concert with the department, will be emailing that survey to all providers with a valid email address and inviting their participation. From here, I think we just close with the contact information. So again, I recognize you've heard a lot from me here this afternoon. you're welcome to reach out to me. When it comes down to the day-to-day work and things like managing the provider survey, that'll be Tina Harper, our lead consultant in this particular engagement, and you'll see her contact information listed there as well. Certainly, I'm sure many of you, if not all of you, know how to reach your favorite people at the department, and they know how to reach us. So you're also certainly welcome to use those channels to weigh in on this rate study as well. I think with that, I know I speak quickly
Yes.
while we're recording this, but we wanted to leave time for Q&A as well with the hour and a half we had today. But before I open it back up, I don't know if Paul or Betsy or anyone else from the department have any comments they want to share.
I do not, Stephen. I think that was a great overview of how the study is going to go. And I know we have some questions in the Q&A, and I hope if you all have questions, you'll keep adding there. Betsy will start walking us through those questions.
Yes, thanks. It was a very comprehensive overview for sure. So thank you for that. So I'm going to start with the questions that are in the chat. If other people want to ask questions, you can raise your hand. I see we have one raised hand, and we'll unmute you, and then you can ask your question as well. So some of them were answered throughout while you were presenting, actually, Stephen. So they got their answers during that time. But the first one is, can you please share the states that you've most recently worked with for comprehensive studies?
Sure, and I appreciate being put on the spot. So I don't forget anybody, but I think if you look at what we've published in 2022 and 2023, those are going to include Georgia, Rhode Island, and Alabama. The map shows obviously all the states in which we've worked, but I think if you're looking for the most recent ones, those are the 3 that have been published in calendars 22 or 23.
Thank you. Paul, I think this one is for you. Question about the service provider tax.
Yes, and whether and when it's being discontinued. Yeah. So if you were following the budget debate this year, you know that the department proposed as part of an agreement with CMS to discontinue the service provider tax that impacts all of you as of the target date, I believe, is January 1, 2025. And so so the service provider tax will not be built into the assumptions for the rates that are being prepared now, and exactly how and when it gets discontinued, TBA. But the goal is January of 25.
Great. Stephen, what is your definition of a true per diem rate?
So for context for all those who are listening in, I'm sure that this is in reference to how agency home support is reimbursed, which, as those of you who provide that service are familiar, it's outlined in the appendix to Chapter 3 of Section 21, where it's an hourly rate, and then the number of hours that home is staffed is used to construct a total cost for the home, then converted to a daily amount on a per person basis. There are, though, expectations of the provider to deliver a level of staffing commensurate with what they're getting paid for. And although I haven't looked at it here recently, that's historically been at least 92.5% of the funded hours. And so to answer the question directly, I would differentiate between the basis of payment and the rules around the management of the reimbursement. So a per diem, to state what's obvious to everybody, it just means that the provider is reimbursed on a daily rate, right? So someone is in states to even define what constitutes a day differently. Delivered service at some point during the day, a head was in the bed at 11:59. There's different ways you can define what a day means, but the idea is you are billing a daily increment per service. So that's what a per diem rate is. The question that the commenter, I think, is getting at is true per diem and what rules are attached to that, and whether or not, for example, there's minimum service requirements associated with accessing that per diem rate, like the 92.5% threshold that Maine Care currently has. And I will say that if we look across the country, when states have per diem rates for group home services, more often than not, there is not the minimum service threshold that's defined as explicitly as it is in Maine, that it's more related to making sure that people are complying with what's built into individual service plans. And so per diem rates can work with or without that specific rule around it. And it's certainly just part of the conversation when we're looking at a reimbursement structure is, are there going to be minimum expectations associated with the per diem rates? And again, there's precedents that point in both directions on that.
Next question, Paul, for Section 21 residential, the DSP rate goes hand in hand with the cost of room and board. What is DHHS doing to ensure that room and board is properly funded? Over the last decade, the state's room and board subsidy has been decimated.
So just to be clear, again, Medicaid under federal policy does not pay for room and board except in nursing homes. And so that's not part of the rate study. It's not a component that is built into the rate. That said, we do have some subsidy that has been paid in the same way at the same amount for many, many years. We recognize that that probably needs an overhaul. It's not in our immediate work plan, but I think as the state addresses housing issues generally, we will be thinking about whether we need to take a different approach to supporting room and board where necessary. And Stephen, if I overstated this from a Medicaid perspective, please jump in, but essentially it's not considered in our rates.
That's absolutely correct. The only thing I would add, Paul, is that in addition to it being the federal policy, states are also expected to provide what amounts to an attestation in their waivers that room and board is not part of this rate. So if you look at any state's waiver and their group home rates, it's going to have similar types of language. That really is a pretty firm delineation point for CMS is thou shalt not include room and board costs in anything that we're paying for.
Misty, I've unmuted you, so you should be able to ask your question. Misty?
You may need to unmute yourself, Misty, because it looks on the screen like you're still muted.
Looks like she logged off. Maybe she was waiting so long. Oh, that's fine. If you come back on, well, she can raise her hand again. Let's see. How often is the rate setting supposed to fairly be? What are the most critical factors that will likely influence rates change?
So to the first question, states are expected to review their rate setting methodologies, which isn't exactly the same as conducting a rate study, but review their rate setting methodologies at least every 5 years, which is the life cycle of a 1915C waiver program. So that's kind of the minimum threshold. And I will say from a consultant's perspective, we think that 4 or 5 year cycle makes sense because it's just so much time and effort and cost to do a rate study like this. It doesn't make sense to do it every year or probably even every 2 years. That being said, as I said, I don't want to give the impression that we don't think that rates ought to be evaluated in the interim. We think they ought to be. Again, I also want to be clear that we know that states have to balance priorities across programs and across state functions. But the comprehensive rate study, to answer the question more briefly, probably every 4 to 5 years. That does not, though, mean that a more regular review of the adequacy of those rates is not warranted. We think that they ought to be reviewed within, in between the rate studies. Then the second part of the question about what are the most critical factors that will influence the rates. The number one factor, as you saw in that home support quarter hour example, is the frontline staff, the direct support professionals. So across the rate studies, it's always going to be the case that that's going to be the single largest expense, typically more than 60% of when you talk about wages, benefits, and productivity. And for those folks who've been involved in these rate studies in the past, you understand how some of those assumptions have kind of magnification or multiplication effects, right? The productivity is an example of that. The lower the productivity, that is the fewer billable hours, the higher the rate is going to be. So for a variety of reasons, both because that's the most critical element to service quality, and also because it's the provider's number one expense. We do spend a lot of time looking at and trying to be as detailed as we can be on the wage assumptions for that frontline worker, whether it's a DSP or a clinician or somebody else. Then outside of that, obviously the overhead costs within my 5 key categories are another expense, but there's ordinarily less variability in terms of things like overhead rates. It's not like some states have a 5% administrative rate and other states have a 30%. That typically trends in a narrower range. So really, there's wiggle room there, but it's not going to be as dramatic, I don't think, as differences you see in things like wage assumptions for the direct support professional.
How will the CIS and lifespan waiver rules interface with these rate studies?
So a number of ways. First of all, I think I said in the opening that the reason we need to do the rates now is because CMS will expect to see them in the waiver application. So, and then ultimately in the rules, the main care rules that are adopted once the waiver is approved. We do expect that the CIS will be required in the lifespan waiver. It'll be something that people will be required to do. And we are the basic concept is to because the CIS identifies needs, it will be helpful with certain payment issues. I think an example that we've used many times is for people with extraordinary medical or behavioral needs, for example. The CIS may be helpful in figuring out who would qualify for add-on payments if we end up going the route of an add-on for those services, or might be useful in other ways. And so exactly how we will tie all these things together, we're still thinking about and working on, but they will definitely all be part of a piece.
And just, there was an earlier question about where to find information. There's the link to Lifespan that was provided there. So lots of information online about Lifespan, including upcoming stakeholder meetings for people to join to hear more about it. Let's see, could you give an example of requirements around per diem rates in other states that are different from Maine?
So without knowing more particularly what the commenter is interested in, I think this is probably tied back to the earlier comment about true per diems. And I'll just reiterate the point I made then a couple of minutes ago is I think the biggest difference is the extent to which there's a formal requirement that I should say a provider delivers the level of support that's built in that per diem rate. So most states that have a per diem rate still have to make assumptions about the level of staffing that rate supports, but then there's not the requirement that providers deliver exactly that level of staffing, or even 92.5% that level of staffing like it is in Maine. I guess the other, I think, distinguishing characteristic as I'm talking this through are when you move to quote unquote true per diem rates, it's also more likely to be fixed rates as opposed to what's happening in Maine where they're variable, right? They're tailored to the staffing within each individual home. Most states with true per diem rates have a fee schedule. That's not to say it's a single rate. Most states have rates that are tiered based upon acuity. So providers are fairly compensated for providing care to people with higher needs. So you might have 3 rate categories or 4 rate categories, low, medium, and high. And obviously I make the numbers up here, but maybe it's $300 to $350 and $400 a day. And then some states further vary their rates based upon the size of the home, with higher rates on a per person basis paid for lower for homes with fewer beds. And so then you're almost left with a matrix, right? Where one dimension is the size of the home, the other dimension is the level of need. And you have 2 home sizes and 3 levels of need. That means you have 6 different rates. So I think those are kind of the 2 characteristics that I think are most common in group home per diem rates that you see across the country is first, it's a fixed rate. And what that means is sometimes the staffing built in is a little bit more than what a provider is delivering, and sometimes it's a little bit less. And to put it kind of more colloquially, it's you win some and you lose some, that it's meant to be an average rather than an exact amount. And then the second factor is because it's meant to be an average, there's less expectation or requirements that the level of staffing be exactly what is provided in one home, because it's recognized that some homes might need more staffing than what is funded, and other homes might need less staffing than what is funded. And the idea is, like all rate model assumptions, it's meant to be a reasonable approximation about what is typical based upon the level of need of the individual, and as I said, in some cases, the size of the home.
Title 34B requires the Commission shall, through contracts and service agreements with community agencies, provide funding to retain qualified direct care workers employed by community service agencies, providing services for children and adults with intellectual disabilities or autism. IDD providers are experiencing high turnover rates and staffing vacancies. Can you speak to how those factors impact the rate setting process?
Well, we certainly are cognizant of the challenges that providers are facing and have long faced. There's, as I'm sure folks are aware, been reports issued over the years about the workforce crisis, and certainly the data suggests that became exacerbated during the pandemic and changes to things like the workforce participation rate. So the provider survey is going to include information about things like turnover and vacancy rates that will be used to help gauge the relationship between things like wages and what those turnover rates look like, and inform some of the decision making. It's not, I will say though, not a one-to-one relationship, right? There's not a formula that we use that says turnover is this and vacancy is this, therefore the wage is this, but it does get considered as part of the overall evaluation of the data. If we're seeing that turnover is 50%, it certainly suggests that wages are probably not where they need to be in order to bring that back down to something that is more manageable.
I think, Paul, this is for you. Will the new rates be available to use 1/1/2025? Billing and reversing billing is very time consuming for providers, and waiting to bill for new rates is not always possible.
So we haven't set 1/1/25 as the precise date of implementation. Just to be clear about that, what we're saying is that ideally we would like to implement 21 and 29 rate updates at about the same time that we implement lifespan, because of, we're, as Stephen said, where there are different expectations across programs, there are likely to be different rates. But where the expectations are the same, we want to maintain parity so that we're not biasing one program over another. There are other technical questions with CMS around maintenance of effort, that if we're proposing certain types of changes in the existing programs, that might have to happen at in a certain period of time. All of which is to say, if I left the impression that these rates are going in place 1/1/25, I want to dispel that right now. It's not real. It's not likely to be 1/1/25 because, given the need to present a major substantive rule to the legislature in 2025. We know that we're not going to be able to begin the lifespan program on 1/1/25. So when we do, however, implement the new rates, we will do everything in our power to have to build in enough operational time to program them into the system so that you can start billing them on the first day, and that's often a big challenge. So I completely understand the question. It is a lot of work for us too when we have to retroactively change the rate. So we would like to avoid that as well.
One area that's been found difficult to understand in the past is program support costs. I hope the survey is detailed in the collection of this data point. I do appreciate the transparency in this process in the past.
So appreciate the feedback. We're certainly open to suggestions on the definitions that we use for program support. So for those, including the commenter here, who I know has completed one or two of our surveys in the past, we do have a definition included in the survey. So folks have ideas about ways that we ought to amend that definition, we're open to hearing it, but it ties back not pretty similarly to what you saw in the presentation. It's more detailed in the survey, but it really is looking at those program-specific expenses that are tailored to individual services. And we try to provide examples like first-line supervision, the QA function, or curriculum development. Sometimes training is more programmatically driven rather than administrative in nature. So as I said, before we release the survey, we'll have a provider advisory group, and that will be one of the things we'll make sure that we point out to them, is that we're looking for feedback on that issue in particular.
Will section 21 and 29 enrollment close prior to the start of lifespan or after?
What I can say with some certainty is that it won't close prior, because we want to continue to provide access until lifespan opens. Whether it closes right on the same day lifespan opens or perhaps a little later is going to depend on some operational details that we work out. Again, the goal is to maintain continuous access to people. So, for example, we might decide that we need a couple of months of rollout of lifespan before we feel comfortable closing 21 and 29. So those though that specific question remains to be decided, but I would say I'm pretty confident that we would not be closing the existing programs until the new one is up at a minimum.
All right. I don't see any other questions in the question and answer or hands raised at this point.
I just want to go back to the question of the frequency of the rate studies, and Stephen did a great job with that question. I want to just remind people that under Maine Care's relatively new rate setting system, rate studies or rate reviews are conducted about every 5 years, with COLAs in the intervening years. So that's the general approach Maine Care has taken. Rebase every 5 years or so, but then in each subsequent year to pay a COLA in the rates based on what's happening with inflation.
And just a reminder, this presentation has been recorded, and the PowerPoint will be shared on the link on the Maine Care rate system. There's a link there in the chat that Nikki provided. We also provided some links to SIS there, as well as again on the Lifespan webpage for folks. I think looks like we've answered all the questions that we've been asked today. I've appreciated this presentation for sure, Stephen, and really appreciate everybody joining us today. There were some really great questions, very helpful.
Great, and I thank you all for coming on pretty short notice. As Stephen said, this is really just the start, and there will be many, many opportunities for input along the way. And as Stephen also mentioned, we are putting together an advisory group of providers that's meant to be representative in terms of geography, size, types of services that you all provide. And so some of you will be getting an invitation from us shortly to help us in a more targeted way, reviewing the draft survey as Stephen said, likely to be the first task that we ask you to help with. So Stephen, did you have anything else you wanted to say before we close?
Nope. Thanks everyone for your attendance though.
Great. Thank you all very much.
All right. Bye.